Okay. All right, so we're hitting the highlights because colorectal is a giant block. So we're gonna knock this out.
Sorry, it's coming. There we go.
Woo.
Okay.
Okay. I'm Kat Thomas. I know all of you, hopefully. So the plan is to hit the highlights for colorectal ABSITE. Now, I think that you guys have probably had multiple ABSITE reviews at this point already. So sometimes the answer on the test is not the most updated answer. Just for everyone's record, the test changed slow. Okay. So anatomy, which is first, super high yield. So this is actually a picture from one of the articles I wrote recently, well, in the last year. But let's talk about kind of blood flow. So what's the blood flow for the right colon? And if you guys don't participate, this is going to be real awkward because there's a lot of questions. So which one? Yeah. And what else potentially? If they have it. Yeah, the right colic. Great. Woohoo. Okay. What about the hepatic flusher? Yeah, so it can be some ileocolic depending on where that splits off, right and middle. What about transverse? Yeah, great. Woohoo. Okay, good. Splenic flexure. Yeah, marginal is fine. The middle colic, yeah, is a portion of it if they have a marginal. And what else? We're on the left side, so the ascending portion of the left colic. Great. Okay, what about for the left colon? Yeah, left colic and the IMA, right? Partially. And then what about for the sigmoid? The IMA, right? The IMA for the sigmoid. Okay. And then the rectum, which I don't have a picture on. Oh, yeah, I do. Okay, so yeah, here we go. Woohoo! There's all the pictures. Okay. And then for the rectum, we got a couple different spots. What about right? What's that? Right. What about this one? Okay, perfect. What about this one? Okay. Woohoo! Good job. They also might be called the hemorrhoidal on the test, just so you guys know. Okay, so that's just for purposes. Venous drainage of the rectum. Where does the superior rectum drain into? Yeah, the IMV to the portal system, right? Okay, but then your middle and inferior rectal, where those drain? Yeah, it's systemic, right? So that's just your difference in lymph nodes when you're doing lymph node basins for cancer. Okay, great. Good job. So we're going to start from the bottom up, anal rectal to start. I had way too much fun making this PowerPoint, guys. I'm sorry. I was post-call. All right. Okay, what's the first line treatment for anal fistula? No. So actually, that's not supposed to be fissure. That's supposed to say fissures. Sorry. First line treatment for anal fissures. Mabi. Conservative. Okay, what does conservative mean?
Fiber, sits baths.
Fiber, yeah, fiber, sits baths, water. That's the thing. Okay, so what happens if your patient fails that? Okay, topicals. So what topicals? What do you start with? Yeah, you can start with calcium channel blockers, or you can start with nitrates. What's the side effect if you give someone nitrates? You get like a question stem, and it'll be like, this guy came in for anal rectal complaints, and then they feel terrible. They've got headaches. Yeah, they get headaches. Okay. So what are our surgical options? Huh? Yeah, so LIS, what else? Botox, correct. You can do Botox. they kind of lump that, and by they, I mean Pfizer and the Behind the Knife book lump that into non-operative management. But I don't know if you've ever tried to inject someone's anus with Botox in the clinic. It's not great. So most of the time you take them to the OR. But yeah, so lateral internal sphincterotomy, great. And then what is the other one? There's another one. We don't do it as often. Most people don't here. Yeah, you can do an anocutaneous advancement flap, okay? And so what is the downside to an LIS? Yeah, fecal incontinence, right? So we have to be careful with those patients. And sometimes now what surgeons will do is they'll trial patients with Botox first. Because if you have if you have fecal incontinence after Botox, then your risk for having fecal incontinence after an LIS is much greater. So that's kind of a relative contraindication. The other contraindications for an LIS. Yeah, if you've had childbirth trauma, they say women of childbearing age because of that risk for childbirth trauma. What else? Yeah, IBD, Crohn's. What else? They also said a history of sphincter dysfunction, and by that I mean they probably just mean if they already have fecal incontinence at baseline. Okay. So those are all kind of, if you see the stem and you see that, you don't want to choose an LIS. All right. Okay, and then what about an anocutaneous flap? Did I put a picture? No, I didn't. There weren't great pictures. So for those, the downside to those is they don't heal as well as kind of the lateral internal sphincterotomies. So those have a little bit more of a lower healing rate, although you do have less fecal incontinence and seepage. So, and those anocutaneous advancement flaps you can do in addition. So you can do like an LIS and a flap at the same time, or you can do Botox and a flap at the same time to try and increase your outcomes. All right. So let's talk about abscesses and fistulae. So this, you can, yeah, you can do it for both. Mhm. Probably not. It's probably going to be an LIS, and it's probably going to be that they have fecal incontinence afterwards before or something like that. But you can technically do an you would cut out kind of where the fissure was, and then you would flap there. Okay. All right. Abscesses and fistula now, not what I have up there, which I'll change before Meg sends this out to the group. Okay, so I put a picture here, but obviously there's multiple different kinds of and places where abscesses can be, right? So this is based on kind of your anatomy. So you have your perianal abscesses, which are more superficial and outside of the muscle themselves. The the intersphincteric abscesses, which are typically between the internal and external sphincters. You have your ischiorectal abscess, which is outside of both, and then you have your supralevator abscesses, which are kind of above the levator muscles. Okay, this is a good picture. I think just keep it in your mind. The rectum is pretty decently difficult to remember anatomy wise because this is 3D and this is one slice of the 3D. So you have to remember that there's kind of 360 where these go. Okay. What's our primary treatment for a superficial or a perianal abscess? Yeah, IND. Okay. I think it's reasonable to say IND for most of these. Okay. The Behind the Knife book makes it a point to note like whether you should do an external drainage versus an internal drainage. I don't know if I've ever seen a question where they've made that distinction, but just so you know. Other people may have. I'm not good at remembering what questions I've been asked. So, okay. So external excise and drain. What about an intersphincteric or supralevator? Yeah, so they say you should try and drain those internally, which makes sense, right? If you've got a supralevator abscess and it's all the way in the rectum, you should probably try to drain that internally as well. Same thing with your intersphincterics. That can be just a technically hard thing to do in general, like, but you're palpating for fluctuants within the anal canal. Okay, and then what about they didn't talk about ischiorectals, but for like a horseshoe abscess. Yeah, what's a Hanley? So it's a posterior, so it's described as a posterior midline incision with counter incisions. Okay, so that's the Hanley. If you talk to some of our staff who do this, you know, like Dr. Jensen likes to put Malin cots in these, depending on who you are. You may be packing them with gauze. It just depends. But it's kind of it. Okay, great. So modified Hanley. So if they say posterior drainage with counter incisions, that's what a Hanley is. And so that's your treatment for horseshoe abscesses. Great. Who gets antibiotics for abscesses? Oh my gosh, Gabs, what does that mean? Yeah.
Chemo or.
Yeah, chemo on chronic steroids, those people get it. Okay, who else gets antibiotics? Yeah, they have cellulitis. And then what's the last one? This is like a no-brainer. These people always get it. Yeah, if they're like septic from this, they should get antibiotics. Okay, great. So what's the risk of developing a fistula from an abscess? If you put a ceton in it, it's 100%. But if you don't, a third. Yeah, so 30% of these people will come back with fistula. 60+% won't. But if you put a ceton in it, it's 100% will come back with fistula. So just, I think, remember that when you're draining these in the middle of the night, not just for the abscess or not just for the ABSITE, but really when you take these people back to the OR is the first one. Okay. And then how are fistula defined? Huh? Yeah, so yeah, they're epithelialized connection between one hole to another. So from inside to outside, right? How do we define we define them by location, right? So you've got your intersphincteric, your suprasphincteric, right? And when we define them, that's how we determine how to fix them. So I guess just remember Goodsall's rule on here about where where the openings of the abscesses may be and where those track to within the anal canal. This helps you this actually can help you when you're looking externally to figure out where you're trying to drain these people at, and where you're looking for the internal opening, depending on where your fistula. Okay, so anterior is all straight tracks, posterior are more curvilinear tracks. So just remember that they'll curve to midline. And then because this is going to take, because we have an hour and it would take a lot. So fistula are defined by where they are. So a submucosal fistula is great. You can, if they present with an ABSITE, or if they present with an abscess, technically you can just open them. If they're, you can open the abscess and you can also do a fistulotomy at index case if you're confident on where this fistula tract is and that it doesn't involve muscles. For the most part, we won't do that. We'll just drain the abscess, but submucosal fistula are great. When you get to intersphincteric, transsphincteric, and suprasphincteric, that's when the goal of you're placing a ceton, the goal is to really try to minimize the amount of muscle that you are dividing. Okay. So those become technically more difficult with ceton placement. And really the goal for that ceton is to have the muscle grow and scar down around where that ceton is so that you can cut the fistulous tract without having to cut a whole bunch of muscle and give them incontinence. Okay. Transsphincteric, you can categorize it as high or low, depending on where it's at with, depending on the actual location within the anal canal and the rectum. Okay. I think that's it for this. Oh, yes. Okay. So these are other things. So like Dr. Hale amended to the anal advancement flap versus your lift procedure. So the lift, this is like, remember 3D, right? So for the lift, you are finding this mature fistula tract within the internal and external muscles, and you are ligating that tract. Okay, so you are creating a flap between the two muscles. You're finding this mature tract and you're ligating that. That's the lift. Okay, so you're really trying to separate this epithelialized canal from being together. So that's what they accomplish here. In addition to that, you might see like fiber and glue plugs, that sort of thing. Fiber and glue plugs are not going to be the answer on your test by themselves. It's going to be a lift, or it's going to be this anorectal advancement flap. So the anorectal advancement flap, you can also do in addition to a lift. But really what you're trying to do is you create a flap that you're then pulling down over the os of the fistula. So you're in essence trying to prevent the bacteria from the anorectal canal getting into that and causing more irritation. Both of these don't have the greatest of efficacy when you do them. Okay, that's why there's multiple different procedures that we do, and you got all that stuff. And now there's like similar to like more on what's in the kind of horizon. There is a similar machine that you use for venous disease, like venous stasis. It's like the burning tube that you use for ligation. You can use those for that now. There's one that's on the market that like glues the tract closed. It's kind of interesting. Anyways, that's not going to be on your test for sure. Okay. Hemorrhoids, everyone's favorite. Oh, yeah. What amount of sphincter is safe to do is fistulotomy? Yeah, 30%, 25%. Yeah. So you want less than 25 or 30% muscle. And for me, that was like hard to like understand what that means. That means like less than, okay? So like closer to the pectinate line. Okay. All right, hemorrhoids. Where is the division between the internal and external hemorrhoids? Medical students. Great. Yeah, the pectinate line. Why is that important? Dentate, pectinate, they call them both. Yeah. Why is that important? Yeah, it's the differentiation between pain fibers. Do not try to ban someone's external hemorrhoid. They will hate you. Okay, so what's the nerve innervation of internal hemorrhoids? Yeah, it's autonomic. They like you don't necessarily have pain receptors up there. So what is it below that line? Yeah, it's somatic, right? So you have those pain receptors. So you don't want to ban those people. That's an important division. Okay. We talked about that. All right. How do we classify internal hemorrhoids? I'll give you a hint. Yeah, the grading system. What is grade 1? Because they might not show you this picture. They may show you a picture of butts. They often like to show pictures of butts on that site. In terms of, you know, you'll get these crazy photos of butts, which I always chuckle at every time they come up. Okay, but what, like, how are they going to describe this one? How are they going to describe a grade 1? Yeah, it's internal only. There's no prolapse, okay? What about grade 2? Yeah, so they're gonna say, yeah, so someone's gonna come in, it's gonna be like a woman or something, and she's gonna be like, oh man, when I poop, I feel this thing, and then it like sucks back in by itself. That's a grade 2, okay? What about a grade 3? Yeah, so this one's gonna be, yeah, when I poop, when I defecate, I have to push something back up into my canal, into my anus. And then what about grade 4? Yeah, it's always hanging out, right? It's just, it's there. You can't reduce it. Don't try. You can't either. Okay. How do you manage hemorrhoids? Like the 1, 2, and 3 for hemorrhoids management. Fiber, how much fiber, Daniel? Yeah, 30 grams is a good even. 25 to 35 is what they say. Okay. What else? Yeah, especially in San Antonio, but also in general. So people will say they'll have like this great high fiber diet, but they won't be drinking enough water. Okay, so it'll cause problems anyways. So fiber, water, and then what else? Toilet habits. What kind of toilet habits? almost new dad. Huh? Yeah, don't, so it's 5, it's less than 5 minutes, so don't sit and like read the newspaper on the John every morning. That's not good. Anyways, can you not make fun of me? I'm giving ABSITE review, Galen, you can't bully me. Okay. Goodness gracious. Okay. What's the management for internal hernias or internal hemorrhoids, God? Yeah, banding them. Okay. It's cat, sorry. Yes. She's been in the hospital for over a week. I am not worried about her being pregnant when she's been hospitalized for 10 days. Okay, all right, great, thank you. Okay, well, that was, great, okay. That was good. All right, so what can you do for internal hemorrhoids? Gabs? No, okay, banding. Sorry, I had to answer that silly phone call. Okay, so you can ban them. Joe, what's the risk of banding? What can happen? What are the complications? Yeah, correct. Be very painful. It can recur. And then there's, they'll bleed. Sometimes they can ulcerate, and there's like a low risk of getting pelvic sepsis or Fournier's. Okay. So banding. Woohoo, good job, guys. What do we do for external hemorrhoids? Yeah. Hemorrhoidectomy. Okay, great. Don't forget that if they're thrombosed hemorrhoids can be incised. Okay, yes. Transhemorrhoidal dearterialization. Yeah, so not a lot of people do this anymore, but it like waxes and wanes hemorrhoidal treatment. But basically what you do is you find where the hemorrhoidal arteries are using a Doppler ultrasound or something, some modality. And then basically it's, you throw a big ass stitch into it. That's how that's accomplished. Yeah, and you ligate it, right? Because there's multiple different inflows. And so the goal for that is you ligate the inflow so that you decrease the outflow to the hemorrhoids. Is basically the one-on-one, hopefully the only vascular I will ever have to do again. Correct. Yes. Okay. What else? Is there more specific questions? Yeah, that's basically it. It was very kind of like Dr. Sanka brought it up the other day about how it was a treatment for hemorrhoids. Like he used to do that in his residency. Okay. All right. Okay, the rectum is prolapsed. Oh no. What do you do for a prolapse? What's the difference between, what does a prolapse rectum look like? Yeah, the typical thing is going to be concentric rings, and you will probably get a picture of this because I think 2 years ago we got a picture of a prolapse rectum. I love these pictures. Okay, so I actually probably do have some photos on my phone of what an actual prolapse hemorrhoid is. But remember the concentric rings, okay? So prolapse hemorrhoids, this B picture looks all nice and pretty, and like you can definitely see the column separation and all of that. When they've got such severe hemorrhoids that are prolapsed and non-reducible, it usually doesn't look like that. It looks like all one kind of big blob. There are some separations, but there's definitely not concentric rings. Okay, so you definitely won't be able to see the concentricity that you would see for a prolapsed rectum. And trust me, I fell into that when I was a PGY too. I thought that I was reducing a prolapsed rectum. It was in fact terrible hemorrhoids. So everyone does it. Okay, so who is the like typical patient that they're going to tell you in the STEM that comes in with a prolapsed rectum? Yeah, it's like an old lady who's either, it can be multiparous and they've had a bunch of babies, or it could be an old demented lady who's on a bunch of antipsychotics and has been constipated for her entire life. Like, it's almost always gonna be an old woman, though. So, okay. What are the different kinds of surgeries you can do for this? There's really there's three, but there's two that they talk about on the boards the most. What? Yeah. So you can do, I think that it's important to make the distinction. You can do just a rectopexy, right? You can do a rectopexy with sigmoid resection if they're super redundant and they've had chronic constipation. That's if they're good operative candidates, right? Mima who's schizophrenic, and on her antipsychotic medications, otherwise doesn't have any other history, right? No cardiac history, anything like that. What if they won't tolerate a general anesthetic or they're not a good intra-abdominal belly surgery candidate? Yeah, you can do an Altemeyer, right? And that's called a perineal proctosigmoidectomy. So what that looks like is basically you find kind of a distal aspect, and it's a very interesting procedure if you've ever done one, but you make an incision into the mucosa and you basically milk out the colon until it gets to a certain part and there's tension, and then you cut that off and sew it to the mucosal incision. It's very interesting. It's a very interesting surgery. Okay, but that's an Altemeyer. Shit. Okay. Yeah, you just. Yeah. Yeah. Yeah,
I don't think the ABSITE would make you differentiate
between a DeLorme and an, yeah,
I think more likely you're gonna get somebody who is not appropriate for his abdominal surgery.
Yeah.
Like a frail lady, like, Pat was saying, and then that's gonna be.
Yeah. Right, yeah, because I mean, even nowadays, like the DeLorme is not used as much because it's not super efficacious. They come back. The problem with an Altemeyer, like just in real life versus a DeLorme, if you do an Altemeyer, you can't do a DeLorme later on. If you DeLorme, you can do an Altemeyer later on. It has to do with the fact that you transect the actual rectum and the redundant tissue, and you're leaving an area that is going to be ischemic potentially. So that's like in real life a thing. When you do the Altemeyer, you need to be aware that that's what you did. Okay. Great. Okay, apparently I had a lot of these things. Oh, the goal for surgery is to eliminate the prolapse, right? So you want to eliminate the prolapse by correcting the functional abnormality, and the functional abnormality in most of these people is they have redundant sigmoid and rectum from chronic constipation. And you want to restore functional, and you want to avoid causing them problems. So really that's in your mind, that's what you're trying to do. And the goal of doing that is dependent on whichever one you want, whatever kind of operative management the patient allows. These people also get high fiber. Okay, you put them on fiber and water. Great. Moving on up. Kind of. Okay, we're gonna start at the sigmoid and move up. Hey, Dr. Martin. Okay, so this is kind of fun because Christina did this for our escape room. So I like that. Okay, so which one of these? So diverticulitis, how do we grade it? The Hinchey classification, yeah, great. So I have these cool pictures with CT representations, which they may give you on the test for those of you who haven't taken it. So which one is Hinchey 1? And we'll say this is from like 1, 2, 3, 4, 5. And they have, just so you know, they have Hinchey 1A and 1B. They differentiate in these pictures. So what's 1A? Yeah, so that's 5. Okay, what's 1B? Great. What's 2? 1. Okay. What's 3? Yeah, the middle guy. And what's 4? Okay, right? So from 1 to 4, we talk about our Hinchey classification. So from 1A and 1B are kind of inflammation of the sigmoid colon, plus or minus a small abscess is what 1B is. So 1B would be an abscess that's less than 3 centimeters. Okay, so a small associated abscess potentially or phlegmon. That's 1A, 1B. 2 is going to be sigmoid inflammation plus an abscess. So that's larger than 3 centimeters. 3 is going to be sigmoid inflammation plus phlegmon plus or minus abscess with purulent peritonitis. And then 4 is going to be feculent peritonitis. Okay. Did I put the other, I don't know if I put the picture on there that's fixed. Okay. So what are our treatments? So what's treatment for Hinchey 1, 1A, 1B? Yeah, antibiotics and bowel rest. Okay. If the patient in the stem comes in and they are tolerating eating and drinking, they just have a lot of pain. Yeah, home with oral antibiotics, okay? That's appropriate treatment. If the patient comes in and they're nauseous or vomiting, they're not keeping anything down. Yeah, they get, exactly. So that will be your distinction. Just remember that in the question stem, like if they're not tolerating diet or they failed kind of outpatient management, either they can't tolerate the pills that you're giving them, that sort of thing, then they need to come in and get treated with IV antibiotics, okay? What about 2? Hinchey 2. Yeah, so it's gonna be drain placement and antibiotics. If the abscess isn't in a place that you can get, that IR can get to it. Yeah, so they make a point to say you could, at that point, if they like say specifically in this question stem that it's not a abscess drainable by IR interventional techniques, a reasonable answer for that would be a lap drainage procedure, okay? Avoid answering like peritoneal lavage for these people. That's not a treatment, okay? Or like washing out the area. That's almost never, that is in fact never the right answer, okay? And then what about for 3 and 4? Yeah, surgical. So 3 and 4, you're going to do surgical. I think for the purposes of the test, in terms of whether or not to decide like Hartman's versus primary anastomosis and DLI versus primary anastomosis, the test makes a distinction that if it's feculent peritonitis to just do a Hartman's. I think in real life, that's not necessarily true. Okay, we know that we can do a primary anastomosis and a DLI even in Henchey 4, and it's okay. As long as you get good resection margins. But for the purposes of the test, if it's feculent peritonitis, then Hartman's is likely the right answer. Okay.
Make it really obvious, like,
Yeah.
it can be a profound shock, fracture.
Yeah.
You know that that's not appropriate. If they're stone cold normal and doing great, you know, they make it very obvious with them. You know, the anesthesiologist looks over the curtain and says, man, he's doing wonderful.
Yeah. It's gonna be
I think
something.
they'll make it obvious.
Yeah, they should make it, there should be something in the stem that pushes you one way or the other. That is obvious. Okay. Great. Okay, so after you diagnose and treat someone for diverticulitis, what do they need next? Yeah, how long? Great. Yeah, 6 weeks. Okay. You're ruling out ischemia, IBD, neoplasm, those types of things. Okay, so that's like you hear diverticulitis, they need a scope. Who gets surgery on an elective basis? Yeah, it's totally individualized. Okay, so it's completely individualized. I think that, you know, for the purposes of the test, they shouldn't really ask you this, but if they've had complicated diverticulitis, and by complicated, they mean an abscess that is greater than 3 centimeters, a fistula, frank peritonitis, those people, like, I don't know why they said frank peritonitis, but like this micro perforation, you see, like, those are not, that's not complicated, but like frank perforation, that sort of thing, those people can get surgery, and then it's really just a discussion with the patient in real life. So I don't think that they'll ask a question that's kind of hard. All right. Now we're moving on to C. diff. It's my one and only question. Any question on diverticulitis? Should be relatively simple. These are great questions. We love diverticulitis. Okay. C. diff infections. Oh man, did I not do it? Okay, whatever. I thought I did my cool thing. So it's a GPR, right? So they'll say like gram-positive rods, blah, 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 and going down on this slide. Non-medical management, so the test still says oral vanc for 10 days is first-line treatment, okay? Just so you know. You can add oral fidaxomicin or metronidazole if it's not severe. Which is kind of silly because we don't necessarily do this. For severe, they say oral vanc or fidaxo for 10 days. And then fulminant, they talk about oral vanc, IV flagyl, and then you can do enemas from the rectum if you need to. Rectal vanc, if they have an ileus. Okay, that's kind of your thing. So just know that the test is not doing fidaxomicin first line. They may have oral vancomycin still. Recurrence. So if they recur and you used vancomycin the first time, you use fidaxomicin this time. If they recur a second time, we just give them more antibiotics. So you make it longer. And a third time, that's when you can consider the fecal transplant that they'll talk about, fecal flora transplant or fecal biota transplant. Surgery. What surgery do you do for this? Yeah. Yeah, so you do a total abdominal colectomy, okay? You leave the rectum in place with an ileostomy. All right.
I mean, you go in and you find one home down.
Yeah. Yeah. Okay. All right. Colonic volvulus. Colonic volvuli. What is this one? What part of the colon is volvulized here? Great. Chris, how do you know that this is the sigmoid that's volvulized?
Because it points to the opposite end of the pelvis.
Right, it points to the right upper quadrant, right? So this is sigmoid. What about there? What's that? Cecal, okay? Similarly, points to the left upper quadrant, okay? So right upper quadrant, left upper quadrant, whatever you want to call them, coffee bean, bent inner tube sign, all of these. This kind of looks like a coffee bean to me too, but they call this one the bent inner tube sign, and that the coffee bean. I just do left versus right upper quadrant. That's how that helps me. Okay. So it looks more like a coffee bean to me. In the book, it says, or they call this one, my right and your left are different, or that one. This one looks like a coffee bean to me, but the book says that this was like a bent inner tube sign also. And then they say like, anyways, I just look at left and right upper quadrant. That's how I do it. They both look beanie. Okay. So if you see a sigmoid volvulus on your KUB, what do you do next? Huh? No, they're not peritonitic. What do you do before you endoscopically detorsion? You get an imaging, right? You can get a CT. So yeah, endoscopic detorsion. And then for the purposes of this, if they're not peritonitic and they're stable, you can attempt endoscopic detorsion. You should leave like a drainage tube of some kind for 2 to 3 days. Okay. What's the downside to doing an endoscopic detorsion, Daniel? Huh? Sure, you can perforate. What else is the downside to it? Yeah, it's got a high recurrence rate, okay? So this is like, I actually did a case like this at Methodist, and he had a sigmoid volvulus. We did a sigmoid resection, so now they're saying you should do, if they're appropriate surgical candidate, and they'll tolerate it, you should think about having a discussion about doing a sigmoid resection while they are at their index admission for this. Okay. Well, I mean, or they've already said it, I just read it, but you know, you should think about doing it at the index case, okay? To let them clear out, you can either prep them beforehand and do like a prep, so then it's less risk of infection.
That and like, you do that,
Yeah.
You need a giant incision just to like. get the terminal.
Right. Mhm.
The other is pins. will be
Or better.
displayed in
Yeah.
angles.
A better size match, yeah. Okay. If they have signs of perforation, if they're peritonitic, yeah, you just take them to the operating room, okay? Hartman's or an open colectomy. Or, yeah, Hartman's. And then they talk about you can also potentially do a primary anastomosis for this too, just like the pitfalls too. You might have size mismatch, that sort of thing. Okay, for the right, what do we do for cecal volvulus? Yeah, don't endoscopically detorse that, okay? That's not the answer on the test. They have to go to the OR. So you resect these, okay? Great. Time is it? 7:48. You guys will all get this PowerPoint, which is great, but, all right, IBD. Ulcerative colitis, buzzwords. What are you gonna see on the test? Huh? Ulcerative colitis, Gabs. Skip lesions, what else?
I'm kidding, I'm kidding.
Oh, no, skip, what? Okay, ulcerative colitis, what are the buzzwords for ulcerative colitis? Crypt abscesses, what else? If it's not skip lesions, it's continuous. Okay, great, what else? Mucosal disease. They'll say it's like primarily mucosal disease, okay? Oh, no, I clicked on the wrong thing. Why is this not working? Sorry, okay. And pseudopolyps, you get a bunch of pseudopolyps, okay? How do we manage it? Okay, steroids first. Okay, what's next? Yeah, so they say steroids, then mesalamine for maintenance, and then biologics, okay, for refractory. This is not necessarily what we do in real life, but this is for the purpose of the test. Steroids first for an acute flare, mesalamine for maintenance, and then infliximab if they're refractory. Indications for surgery. Okay, fulminant is one, yeah. What else? Yeah, failure, sure, what else? There's a big one, that's fulminant. Malignancy, they have cancer, okay, malignancy, and then other complications, right? Stricture, perforation, fulminant. They, so for medical intractability, what that's gonna mean is for kids, they're gonna have growth failure. So if they're a child with ulcerative colitis, they're not gonna be growing, they're gonna be falling off the growth chart. That's a big one. For adults, it's gonna be just worsening on kind of their maintenance therapy. It's not getting better. They're still having symptoms or they're not going away or improving. And if they have disabling extraintestinal manifestations. So what are those extraintestinal manifestations? Okay, so yeah, PSC, arthritis, what else? Yeah, uveitis and skin, right? Erythema nodosum. Okay, so which one of these does not respond to taking your colon out? Right, okay, so yeah, that's the one that's not gonna get better when you take the colon out. Ulcerative colitis still. What is the surveillance recommendations for colonoscopy? Are we in the OR? Okay. What? Yeah. 8 years after, and then every 1 to 2 years after that, okay? You wanna do 4-quadrant random biopsies at 10-centimeter intervals, and obviously if something looks suspicious, you take a biopsy of it, okay? This is like simplified, we could have a whole 1-hour-long conversation about colonoscopies for ulcerative colitis and Crohn's, because it's not necessarily this simple, but surgical approaches, emergent procedure you're gonna do? Yeah. Yeah, a total or subtotal colectomy with an ileostomy, correct. What about if it's elective? This, you got options. Huh? A 2-stage what? Yeah, so there's a couple different options for this. Actually, you can do a total proctocolectomy with endoleostomy, knowing if you do that, they're gonna have an endoleostomy, okay, for life. You can also do an ileopouch anal anastomosis as well. The big thing for that is make sure that the patient does not have Crohn's. Okay. And then you can do a total abdominal colectomy with an ileoanal anastomosis. If you do a TAC with IA, they need to have annual surveillance of their remaining rectum. Okay. So they get annual scopes of that rectum that's remaining. Same thing if you do an ileopatch anal anastomosis, they still need to have annual surveillance of that the rectum that's left. Okay. Crohn's disease. Buzzwords for that, GABS. Yeah, transmural, skip lesions. And then on imaging, they're gonna say like creeping fat or something like that, or you're gonna see creeping fat on the imaging. Okay, management. Yeah. You guys are mumbly today. So steroids for flares, 5-ASA or mesalamine for maintenance, and then if it's resistant, anti-TNF. Specifically for Crohn's, anti-TNF therapy, so adalimumab and infliximab are specific for what types of Crohn's you want to treat. Yeah, fistulizing and perianal. So that's a treatment of choice for those. Got fistulizing or perianal, you want to do adalimumab or infliximab. Okay. Indications for surgery for Crohn's. Yeah, if there's strictures and things aren't getting by. So any complications of the disease, right? Depending on what kind, there's multiple different subtypes of Crohn's. So strictures are a big one, fistulae, abscesses, types of things. I think in real life and practicality, Crohn's is very difficult because they're like the colorectal version of vascular patients. They continue to get shorter with everything we do to them. By their gut, like it's getting smaller and smaller. So you just need to be very intentional when you do operate on them to try and preserve as much length as possible. Extraintestinal manifestations of Crohn's. Yeah. So arthritis, arthralgias, megaloblastic anemia, uveitis, erythema nodosum. Great. Woohoo. Same stuff. Why do they get megaloblastic anemia? Yeah, because of terminal ileitis. Great. They have decreased absorption of B12. Okay. What are our approaches for strictures? Okay. Okay, so less than 10 centimeters, what type of strictureplasty? That's what you guys are getting at. What type are you gonna do? Yeah, you're gonna do a Heineke-Michelix. What is that, Galen? How do you do a Heineke-Michelix?
You make along the bowel and then.
Yeah, great. Okay, what about for 10 to 20 centimeters? Great, good job. A finished strictureplasty. It's very similar. You make a longitudinal incision as well and you fold it onto itself. I have a picture next. And then what about greater than 20 centimeters? Yeah, it's like side to side isoperistaltic, which is like a very long mini. Okay. All right, so here we go. So Heineke-Michelix, right? You make an incision across and then you close it transversely. Okay, so horizontal incision across the stricture. It's got to be small stricture, less than 10 centimeters. And then you can bring it back together transversely versus a finny. So this picture was kind of confusing to me. You make this incision long across the stricture and then you squish it down like this, okay? And then a side-to-side isoperistaltic is very similar to what we do. You're making your common channel across the kind of stricture. So, all right, okay. I have to go to the OR and we're gonna go to cancer. But there's a bunch of cancer. We're not starting from the bottom up. But Meg has this PowerPoint. She can send it to everyone. Okay. Thank you. I told you it was a lot of things to do in one ABSITE review.
Thank you.
Okay, thanks, Meg.
Okay, we can take a 5-minute break and then we'll start M&M.
So 50-year-old man.